Welcome, I'm Tracy from the Stabilisation Academy, and in this short clinical video we're going to rethink one of the most misdiagnosed problems in the lower limb rehab, and that's heel pain. More specifically, we're zooming in on the diagnostic trap of automatically assuming it's plantar fasciopathies, because in reality it often actually isn't. So let's take a look at what heel pain could be and if it's not what we think. In fast-paced clinical settings, we often lean on pattern recognition. So for heel pain, that typically sounds like it hurts in the morning, the pain is medial, so it must be plantar fasciitis. But that's where we get caught. True clinical reasoning involves asking better questions. What tissues are involved? What's the load response? And does the patient's history support this diagnosis? When we assume instead of assess, we risk treating the wrong problem altogether. Now, how often have you heard this? My orthotics didn't help at all. This doesn't necessarily mean orthotics don't work. It often means you're applying a fascia-based intervention to a non-fascial problem. If the real issue is Baxter's nerve or a calcaneal stress reaction or even a bruised fat pad, then supporting the arch won't address the source of the symptoms. This kind of treatment mismatch isn't a compliance issue, it's a diagnostic issue, and it's one of the most common reasons for failed rehab. So let's break down what we're really dealing with when heel pain persists. First, plantar fascia pain is medial, worse in the morning, and classically responds to load modification and graded rehab. Nerve entrapment issues. You touch the person, they will flinch. It's sharp, electric, radiating, and it can happen when they're standing or not standing, throbbing, that sharp stabbing pain that just won't go away. And they're classic signs of neural involvement that won't respond to stretching or orthotics. And in fact, stretching will make it worse. Fat pad syndrome. It's deep, it's central, and worsens with impact. So bone stress is aggravated by weight bearing and may show bruising or subtle swelling. And don't forget Achilles insertional pain or compressional pain, which can mimic plantar symptoms, but it sits more posteriorly at the back of the heel. And then there's tarsal tunnel syndrome, and that's when medial ankle pain has neurological features. The first case was with a 42-year-old recreational runner, and he came in with persistent heel pain. He was already wearing orthotics and was doing heel drops and calf raises, and it wasn't working. It was getting worse, and with any movement up or down, the pain was sharp, it was on the outside, and it worsened during activity. It throbbed at night. And it turned out to be Baxter's nerve entrapment, not plantar fasciitis. So once we changed the treatment to do some neural gliding, some neural therapy, some fascial manipulation, the symptoms improved within weeks. Now, assessment does not end at palpation. Movement reveals everything. In gait, does the patient avoid heel strike? Do they prematurely push off to avoid loading? In DNS-inspired positions, are they collapsing medially or struggling to stabilize through the foot and tripod? Does a single leg stance reproduce symptoms or expose trunk control deficits? Heel pain is often a compensatory pattern. It's not just a local issue. So we always have to observe up the chain because the problem may originate from above. Now, rehab doesn't fail because your exercises are bad. It fails because they're pointed at the wrong target or you've got the wrong part of the movement that you're treating. So loading a nerve when you think it's fascia can flare symptoms and damage patient trust. So we must move away from treating pain in isolation. We have to treat the system, not the symptom. You can't out rehab a misdiagnosis no matter how many real heel raises or arch taps you assign. Now, 3 quick takeaways to improve your heel pain outcomes. Number 1, always rule out a neural contributor. Even subtle signs like tingling or pain at rest should raise your suspicion. Number 2, palpate with precision. Just don't poke the medial heel. Map the full pain zone. I usually like to use an X marks the spot. Central, posterior, lateral, it tells you everything. And number 3, don't get stuck at the foot. Look up. Faulty trunk or hip control often creates repetitive overload that ends up in the heel. If you're ready to upgrade your approach to heel pain and move beyond the plantar fasciitis reflex, join us at the Stabilisation Academy. We've got short courses, tools, and mentorship to help you treat more accurately, more confidently, and with better outcomes. Because when you diagnose with clarity, everything changes. I'm Tracy Smith, and I'll see you next time. Ciao.